Welcome to our in-depth exploration of cardiovascular diseases, CVD. In this new series in the channel, we will give a complete and detailed summary on common disorders of cardiac function. If you would like to review aspects about normal cardiac function, feel free to take a look on our YouTube channel, where is already a complete playlist about it. Well, for this series, we will use as main source the book of Porth's Pathophysiology, 9th edition. We will focus specifically on Chapter 32, Disorders of Cardiac Function. Cardiovascular disease, CDV, is the leading cause of death in men and women in the United States. In an attempt to focus on common heart problems that affect persons in all age groups, this chapter is organized into 6 sections. 1. Disorders of the pericardium. 2. Coronary artery disease. 3. Cardiomyopathies. 4. Infectious and immunologic disorders of the heart. 5. Valvular heart disease. And 6. Heart disease in infants and children. We will be discussing each topic in detail. In this instance, this first video of the series about the cardiovascular disease will cover disorders of the pericardium in 3 parts. Here's the index of topics. Part 1, disorders of the pericardium, generalities, classification, acute pericarditis, clinical manifestations, diagnosis, treatment. Part 2, pericardial effusion and cardiac tamponade, pathogenesis, diagnosis, treatment. Part 3, constrictive pericarditis, etiology and clinical manifestations, diagnosis. Let's dive in. Generalities. The pericardium, sometimes referred to as the pericardial sac, is a double-layered serous membrane that isolates the heart from other thoracic structures, maintains its position in the thorax, prevents it from overfilling, and serves as a barrier to infection. So, the pericardium consists of 2 layers. A thin inner layer, called the visceral pericardium, that adheres to the epicardium, and an outer fibrous layer called the parietal pericardium, that is attached to the great vessels that enter and leave the heart, the sternum, and the diaphragm. These 2 layers of the pericardium are separated by a space called the pericardial cavity, which contains about 50 millimeters of serous fluid. This fluid acts as a lubricant that prevents frictional forces from developing as the heart contracts and relaxes. Although there is little blood supply to the pericardium, it is well innervated and inflammation can cause severe pain. The pericardium is subject to many of the same pathologic processes, for example, congenital disorders, infections, trauma, immune mechanisms, and neoplastic disease that affect other structures of the body. Pericardial disorders frequently are associated with or result from another disease in the heart or the surrounding structures. Here's the table 32.1 of the chapter where we can look at the classification of disorders of the pericardium. We have the first aspect, inflammation, which can be subclassified as acute inflammatory pericarditis. 1. Infectious, whether viral, echovirus, Coxsackie virus, and others, bacterial, for example, tuberculosis, staphylococcus, streptococcus, or fungal. 2. Immune and collagen disorders, rheumatic fever, rheumatoid arthritis, systemic lupus erythematosus. 3. Metabolic disorders, uremia and dialysis, myxedema. 4. Ischemia and tissue injury, myocardial infarction, cardiac surgery, chest trauma. 5. Physical and chemical agents, radiation therapy, untoward reactions to drugs such as hydralazine, procainamide, and anticoagulants. Chronic inflammatory pericarditis can be associated with most of the agents causing an acute inflammatory response. The second aspect is as consequence of a neoplasties, primary or secondary, for example, carcinoma of the lung or breast, lymphoma. The third and last aspect is given to congenital disorders, complete or partial absence of the pericardium, congenital pericardial cysts. Let's begin with acute pericarditis. Pericarditis represents an inflammatory process of the pericardium. Acute pericarditis is defined as signs and symptoms resulting from a pericardial inflammation of less than 2 weeks and may occur as an isolated disease or as the result of systemic disease. Among the causes, viral infections, especially infections with Coxsackie viruses and echoviruses, are the most common cause of pericarditis and probably are responsible for many cases classified as idiopathic. Other causes of acute pericarditis include bacterial or mycobacterial infections, connective tissue diseases, for example, systemic lupus erythematosus, rheumatoid arthritis, uremia, post-cardiac surgery, neoplastic invasion of the pericardium, radiation, trauma, drug toxicity, and contiguous inflammatory processes of the myocardium or lung. If we dive in explaining some of the pathophysiology of the acute pericarditis, we can start by saying that, like other inflammatory conditions, Acute pericarditis often is primarily associated with increased capillary permeability. This means that the capillaries that supply the serous pericardium become permeable, allowing plasma proteins, including fibrinogen, to leave the capillaries and enter the pericardial space. This results in an exudate that varies in type and amount according to the causative agent. Acute pericarditis frequently is associated with a fibrinous, fibrin-containing exudate, as is shown in the figure 32.1 of the chapter, where we can see the heart of a patient who died in uremia displays a shaggy, fibrinous exudate covering the visceral pericardium and therefore resulting in a fibrinous pericarditis, which heals by resolution or progresses to deposition of scar tissue and formation of adhesions between the layers of the serous pericardium. Inflammation also may involve the superficial myocardium and the adjacent pleura. Clinical manifestations. The manifestations of acute pericarditis include a triad we need to remember: chest pain, pericardial friction rub, and electrocardiographic ECG changes. The clinical findings may vary according to the causative agent. Nearly all people with acute pericarditis have chest pain. The pain usually is abrupt in onset and sharp, occurring in the precordial area, and may radiate to the neck, back, abdomen, or side. Pain in the scapular ridge may be due to irritation of the phrenic nerve. The pain typically is worse with deep breathing, coughing, swallowing, and positional changes because of changes in venous return and cardiac filling. The person often finds relief by sitting up and leaning forward. It is important to differentiate the chest pain from pericarditis from acute myocardial infarction or pulmonary embolism. Diagnosis. Diagnosis of acute pericarditis is based on clinical manifestations, ECG, chest radiography, and echocardiography. A pericardial friction rub, often described as high-pitched or scratchy, results from the rubbing and friction between the inflamed pericardial surfaces. The friction rub is typically described as having three components, which correspond to atrial systole, ventricular systole, and rapid filling of the ventricle. Because it results from the rubbing together of the inflamed pericardial surfaces, large effusions are unlikely to produce a friction rub. Except in uremic pericarditis, the ECG changes in pericarditis typically evolve through four progressive stages. 1. Diffuse ST segment elevations and PR segment depression. 2. Normalization of the ST and PR segments. 3. Widespread T-wave inversions. And 4. Normalization of T-waves. Laboratory markers of systemic inflammation may also be present, including an elevated white blood cell count, elevated erythrocyte sedimentation rate, ESR, and increased C-reactive protein, CRP. Increased CRP is not present in all cases. However, it can be used to monitor disease activity and length of treatment needed. Treatment. Acute idiopathic pericarditis is frequently self-limiting and presumed to be viral. Symptoms are usually successfully treated with non-steroidal anti-inflammatory drugs, NSAIDs. Colchicine can be added to the treatment regimen and has also been shown to be of benefit in people who have a slow response to NSAIDs. Colchicine produces its anti-inflammatory effects by preventing the polymerization of microtubules, which leads to the inhibition of leukocyte migration and phagocytosis. When infection is present, antibiotics specific for the causative agent usually are prescribed. On the other hand, corticosteroids may be used for treatment of persons with connective tissue disease or severely symptomatic pericarditis that is not responsive to NSAIDs and colchicine. Corticosteroids should be avoided if possible due to an increased number of reoccurrences associated with use, if not related to autoimmune diseases. However, if it cannot be avoided, only a short course of corticosteroids should be initiated. Relapsing pericarditis can occur in up to 30% of people with acute pericarditis who respond satisfactorily to treatment. A minority of these people develop recurrent bouts of pericardial pain, which can sometimes be chronic and debilitating. The process commonly is associated with autoimmune disorders such as lupus erythematosus, rheumatoid arthritis, scleroderma, and myxedema, but may also occur following viral pericarditis. Treatment includes the use of anti-inflammatory medications such as NSAIDs initially, and then treatment with colchicines. If reoccurrence continues, colchicine prophylaxis is warranted. If colchicines are not tolerated, then low-dose corticosteroids can be initiated. Thank you so much. This is all for this part. In the next part of disorders of the pericardium, we will cover pericardial effusion and cardiac tamponade, aspects such as pathogenesis, diagnosis, and treatment. If you found the content useful, don't forget to like the video and subscribe to keep track of all our content. Welcome.